Decreased perfusion to organs.
Yeah. So yeah, decreased perfusion to organs is what was said. So yeah, exactly. Shock is defined by inadequate perfusion of tissue. So the oxygen that's being delivered does not meet the metabolic demand that the tissue needs. And then the pathophysiology of why that tissue is not getting enough oxygen changes depending on what's going on with the patient. So there are a few different types of shock. Anyone want to name one or two? Septic, cardiogenic, distributed.
Hypovolemic.
Okay. Okay, so I see we're naming all sorts of types or causes of shock. Okay. Not all of those are necessarily types of shock, but those are all causes of shock. So these are our types of shock. We have hypovolemic shock, and that's just your circulatory volume is depleted. You can either be really dehydrated or you can be bleeding. And then you have distributive shock, which you said septic shock. So septic shock is actually a form of distributive shock. And that's, so distributive shock is when you have vasodilation. And so like when you're septic, you have all the cytokines that are causing vasodilation, and then your blood pressure is low, you don't have enough oxygen being delivered. So sepsis, anaphylaxis, endocrine causes, anyone know the endocrine causes? Nope. Yep. Adrenal crisis and neurogenic. Those can all be, those are all causes of distributive shock. Sometimes they'll throw at you a spinal shock on a test question, and a spinal shock is very different from neurogenic shock. A neurogenic shock is if you have a spinal cord transection, and a spinal shock is temporary, it gets better, different. Obstructive shock. So this is when you have anything that's obstructing your heart or your great vessels. This you see in the tension physiology, so tension pneumos, hemothoraxes, tamponades, and then also a very large pulmonary embolism. So yeah, large pulmonary embolisms will also cause obstructive shock. It impedes the outflow, and you get right heart failure.
Adaptation of that. Less PD with the cardiac arrest. Yeah.
Yeah, I've seen that too.
Survivable?
CPR.
That's the one that got back.
That's one that we got back.
Did you guys follow them?
Yeah.
Wow. Yeah, there are no slides on this one further, so interesting tidbit. You know how we can do ED thoracotomies?
Yeah.
So in the ACS lecture, it was saying that if you knew a patient was having a huge PE, you could technically do a thoracotomy.
Really?
And then do like manual or compressions of the heart, because it's distributive, so the heart can't beat against the block.
Right.
So you can beat the heart,
Oh,
but you'd have to know. And so I don't actually know of very many circumstances where you would ever be able to do a thoracotomy.
Yeah.
Yeah, I was just thinking, like, what kind of circumstances would
Right.
ever be, like, I can't even like, line them up that I would feel comfortable.
Making that, yeah.
Yeah.
That's a big
Big,
decision.
yeah, big thing.
So, and then cardiogenic shock, that's when the pump of the heart is failing. So the heart is failing to pump, which is different than obstructive, is where the heart's okay, it's just it can't beat against that block. And then undifferentiated shock, patients who don't meet those above classifications. And then you can also have patients who have mixed shock. So we get this a lot with our trauma patients. So you can have hemorrhagic shock and neurogenic shock all in one, or hemorrhagic and septic, and then also you see a lot of septic and cardiac together as well. And so when you get a patient,
I have a question.
Yeah.
How would you tell the difference between hypovolemic shock and like distributive shock, like from sepsis?
hypovolemic and distributive shock, that is, we get there.
Oh.
So when you approach like our patient's vitals, kind of looking at what he had, right? Patient was febrile to 101, his heart rate was 121, respiratory rate was high, and his O2 was what, 94% on board. So approach to vitals. So your temperature, when you guys go into that sepsis calculator thing, right, you get either hypothermia or hyperthermia. So fever, if your patient has a fever and they're in shock, this would tell you to look for any signs of infection. And then if they're hypothermic, this could also be an infection, or it could be that pesky adrenal crisis. You can thyroid, like a myxedema coma thyroid, you can also get some hypothermia. I've really only ever seen that once. It's pretty uncommon. And then your heart rate. Most of the time, heart rate is going to tell you a lot. So your heart rate is typically elevated in a patient who is hypotensive because it's the compensatory mechanism, right? Your blood pressure is low, your heart rate goes up to keep your cardiac output kind of steady to perfuse your organs. So distributive and hypovolemic shock, both the heart rate will be elevated. And then that is the formula that we all know very well. And then if you have a bradycardic or a normal heart rate, that would push you more towards thinking about neurogenic or cardiogenic shock. And then what about patients with normal heart rates? So it included in the ACS document that you guys got, it mentioned inappropriately low heart rate for the patient presenting with shock. But I would also like to comment on the normal heart rate patient presenting with shock. Because patients on beta blockers, they'll block your response. And then elderly patients also, they don't really get that tachycardia. You can have somebody who's super sick, super septic, and then have pretty normal heart rate, so you can't rule that out. Your young, healthy people, they're the ones that get really tachycardic because they have that reserve. And then blood pressure. So hypotension in ICU and trauma, critical care, we don't really use a systolic to measure our hypotension like you guys do normally in medicine on the floor, but we use a MAP, a mean arterial pressure of less than 65. Does anyone remember how to calculate that? MD Cal.
Like 1/3 like systolic minus diastolic, something like that.
Okay, so your heart, when it beats,
Yeah.
it spends time in systole
Yeah.
and diastole. Which does your heart spend more time contracting, or does it spend more time relaxing? More time relaxing.
Yeah.
So what did you say?
1/3 times systolic.
So you spend 1/3 of your time in systole and 2/3 of your time in diastole.
Yeah.
So mean arterial pressure is 1/3 systolic plus 2/3 diastolic. Make sense?
Yeah.
Okay. There are algebra. You can rearrange that equation in a million different ways, but that is the most simplified way that I found it. So hypotension, you're going to see if you have your patient in shock. They may present with hypertension or some swings, hypo, especially as they're decompensating in that little period. And then people who live at a higher blood pressure. So, we have people who come in with a systolic blood pressure of 200. So their system is used to that high blood pressure. So if we drop it, or if they're appearing normal, it's not normal for them. So we have to remember that. And then respiratory rate. Tachypnea, we often see tachypnea. We have these patients are often going to be in shock. They're not delivering enough oxygen to their tissues, so they become acidotic. So typically their respiratory rate goes up to blow off the acid. And then their oxygen saturation, they can typically preserve, it's typically preserved by increasing the oxygen extraction. Remember those oxygen curves that we all loved in medical school? And then a very late hypoperfusion does our oxygen saturation decrease. And then we also have to remember, we can see these mismatches, pulmonary embolism, pneumothoraxes, all of these fun things. So you get a patient, they're in shock. What is your initial evaluation? This is really small. So you guys have all seen us do trauma. Very, very, very similar. Our approach to the ACS patient is very similar to our approach to the trauma patient. So we start with what? The airway. So you have to ensure that their airway is patent. How do you do that?
Like checking if they have obstruction in their mouth, maybe because swallow something.
Yeah. What about something easier?
Are you breathing?
Talking to you?
Talking. Hey, sir, what's your name? Right? If they can tell you their name, their airway's not obstructed. Sometimes you literally have to stick a finger in their mouth, make sure there's nothing back there. So you check to see that their airway is patent. Other things, is their tongue big and swollen? Is their mouth big and swollen? Are they shot in the mouth? Kind of going into trauma. Anaphylaxis, is their tongue swollen? Is it a burn patient, like inhalation, edema? And you also want to look at the trachea. Is it deviated? So tracheal deviation, y'all learn that's a sign of a tension physiology, tension pneumothorax or chemothorax. And then also for the airway, you have to pay attention to their mental status. Trauma, we use the GCS to calculate the mental status, but that's not really in like the ACS. So altered mental status, or GCS of less than 8, you have to less than 8 intubate, because it can't protect their airway. And then, so these patients, you actually need a definitive airway. Do you guys know what a definitive airway and what is that? What does that mean? So we got these people coming in. Sometimes the ED, they'll get those those LMAs, those tubes that sit behind your tongue, or sometimes they'll get maybe a trumpet or something to help with airway. But what is a definitive airway? Yes. An ET tube is a definitive airway. You guys know the definition of a definitive airway? All right. It's a tube that passes through the vocal cords with a balloon. So anything that goes through the vocal cords with a balloon, that is your definitive airway. Or into the trachea with a balloon. So, right, if we do a trach, that is a definitive airway, but it's not through the vocal cords. Breathing. So we have airway. Now breathing. Breathing is different than airway. So breathing, you're going to make sure that you can hear breath sounds on both sides of the chest. Are they equal breath sounds? Do you hear decreased or absent breath sounds? Decreased or absent breath sounds, that would point you to that they are bleeding or that they have a pneumothorax on that side. While you're going through the ABCDEs, if anything changes on your patient while you're going through, you start back at A. So if we're seeing the patient has an airway, now I'm listening to their chest, but they stop talking, their GCS changes, you always have to go back to the beginning and work your way down because this can change at any time.
And I think the other thing is, obviously you're concentrating on the acute issues to get the patient through that moment, but you should be kind of also simultaneously coming up with a differential. Especially on not necessarily a trauma that's rolling in the door, but like an ER patient or somebody who crumps on the floor. What is a reason this could be happening? Because it's not like they just had a crush injury to their trachea. Why are they decompensating like this?
Exactly. So we always say A, B, but you're really doing 20 things in your head at once. You're planning ahead, you're thinking ahead, and you're telling people what to do. So in circulation, you're going to assess for peripheral pulses. Can you feel pulses, places, because an IJ you can feel at a lot lower of a blood pressure than you can a radial artery. Like when we're doing CPR, you should never check for a radial artery because it's silly. And then this is where you're going to get your IV access. So for a patient who's in shock, who's bleeding, whatever, you need to establish access. So the definition of access is 2 large bore IVs, greater than 2 large bore IVs. So different resources say different things. So it's either a 14 or a 16 gauge IV counts as a large bore. So you need 2 of those. You can't get 2 of those. Anyone else know what you can get? What you can put in? An IO? Yep. And one other thing. Central line. Exactly. So those are the other options. So once you have established access, then you're going to resuscitate your patient. In our sick patient on the floor, they're not bleeding, so we're going to give them fluid. Last time we met, I heard 2 different answers for how much you give your initial volume. And it's funny because in the 2 different ACS documents, the electrolyte and fluid document versus the shock document, they gave 2 different volumes of what you give. So the standard is actually kind of what we say is 2 liters based off the average weight of the person. If you use the 20 cc's per kilogram, it ends up being like 1.7 liters. So we just give 2 liters. But if you want to calculate it, you can use the 20 cc's per kilogram or 30 cc's per kilogram. And then the preferred fluid for initial resuscitation. LR. Yep.
Lactated.
Sorry.
Why?
Oh, because it's isotonic, but it has the most. It's like dense.
Isotonic fluid. And then you typically don't give NS for large volume because it can cause a metabolic acidosis. And then if they're bleeding, you're going to stop any bleeding. You can look at their jugular veins, see if they're distended, because that can be a sign of, once again, our tension or tamponade physiology. And then you're going to assess perfusion to the distal extremities. So the acral cyanosis, if their extremities are cold, clammy, that is more consistent with the obstructive, hypovolemic, and cardiogenic shock. This is what Dr. Harris was saying earlier. How can you kind of tell the difference on your exam between cardiogenic versus septic shock? So your septic shock patient, they're the ones that are warm, red, all of that. So they're going to be the warm, dilated shock versus the acral cyanosis shock. Then disability. So this is where we're going to do a full neurologic exam. We're going to do motor and sensation. Really isn't relevant to our ACS patient unless they fell on the floor or had a stroke. But
Which happens.
yeah,
Both of
unfortunately,
those things.
more than you
Unfortunately.
want. But yeah, this is more big in our trauma patients. Are bones broken? Are they moving things?
And seriously, with that, there's stuff that happens, patients you don't know. They fell down and someone put them back in the bed and it's never been reported in the document. So really try to keep an open mind with all of it, because we have literally seen those things happen, paralysis from falling out of bed in the hospital, strokes that went unwitnessed and kind of uncovered. So, you have to kind of keep it all in your brain when you're working with these folks.
Very much so. And then exposure and secondary evaluation. So exposure, look at the patient's whole body, see if there's signs of infection. Do they have a huge red leg with a wound that looks like it's going to fall off? Are they bleeding? Do they look dehydrated? Do they look volume overloaded? And then really important at the end of this is you need to prevent hypothermia of your patient. So if you take all their clothes off, you need to recover that. On your ATLS, you will fail if you do not recover your patient. And then this is for hemorrhagic shock. You guys are going to see this all the time, even if you don't go into trauma, because in surgery, patients bleed. So the important thing to notice on this one is that if your blood pressure is normal until you lose 1.5 liters of blood. And that's a pretty significant amount of blood. Your pulse goes up pretty quick. Your heart rate goes up when you lose just a little bit of blood. And then your urine output also is something. Once your urine output becomes, like once that drops to abnormal, you're in danger zone. And then once your patient is also like confused and lethargic, danger zone. So I think we see a lot of blood loss here too. Like you guys are gonna have a skewed point of view of what's a lot of blood. So just like we see these patients coming in already confused and lethargic, and so just that's bad. So you need to catch this early. So think about as soon as you see the pulse pressure changing, as soon as you see a little bit of tachycardia, just have it be in your differential. And maybe they could be bleeding.
They like to ask about pulse pressure on exams. And the easiest thing I think is to memorize stage 3, because then the other ones are easier to kind of, even if you don't have it memorized, kind of remember. And they mostly ask about stage 3.
Mm-hmm.
So
yeah, because that's when the blood pressure drops, that's when your urine becomes abnormal, all of that. And that could be up to 40% of your volume, right? Okay, so now we need access in our patient. So we talked about this earlier, what counts as access. So 2 large bore IVs, typically 14 or 16 gauge, 1 on each arm, would be great. An intraosseous IO. So these are all the different places that you can put an IO on an adult. I've only seen them in the proximal tibia and the humeral head in adults. But these are all different places that you can put them. There are different colors. So there's the yellow, that's for larger patients, more obese. You got to get through more soft tissue before you get your bone. Blue for normal sized people, and then pink for smaller patients and babies. And the only 2 things that you can't or you don't want to give through an IO is adenosine for SVT. It's not as effective. And then platelets. You can give every other blood product and pressor through an IO except for platelets, because the platelets are too big. And so when it's like traveling through the bone, they just get shredded and they don't end up working. And central lines.
can you kind of give an idea, are you going over intraosseous? Can you just give an idea of what it's like to put that in?
Yeah, it's a fun drill. We do a lab. I've never done one on a human, but I've done them on models. It's like this little red little power drill, and you literally just drill into the bone. So you find the best place to do it is like the tibia right here. And you find it in like the flat side, the medial tibia, underneath the tibial plateau, because that's where it's the thickest, and then the skin and the soft tissue is pretty thin. And your bone has 2 cortexes. I don't know if any of you guys are into carpentry, or ortho. If you guys have ever done ortho, you've felt the cortex. So you drill until you feel the first cortex, and then it's kind of like drill, then it will pop through, and that's when you know that you're in. You want to make sure you don't go through the bone. So you felt on the cortex.
So
You
it's
can
like
get
feedback.
the feedback. You feel it. You can get compartment syndrome from this. You can break the tibia from this as well. And then you can cause some infiltration issues if the end of the needle is not like in the bone. Typically, these are short-term things. So you put in an IO, you stabilize the patient, and then you take out the IO. And you get
Have
other
you
access.
found that when you did that, that you were really helped the resuscitation and you were able to get the IV later or the central line later? Did you notice a demonstrable difference?
No.
It's kind of like extremis situations a lot of
It's
times.
extremis.
And
My
then-
patient's dying.
What about anything you need to do to make sure you're in before you start the fluids? Just knowing you got that feedback.
Yeah, because most
And
of the time,
there's no infiltration, so
and most of the time it's in the field too. Like EMS can put in IOs, and the nurses will put in IOs. So we don't do anything. Literally, as soon as it's drilled, we're hooking stuff up to it, and then you just look at the limb that it's in and make sure the limb isn't becoming super swollen. But like Dr. Martin was saying, this patient's an extremis, so all hands on deck. And then for the central lines too. So the 3 places that we put central lines are the IJ, subclavian, and the femur. There's a lot of opinions and thoughts about which locations are better. Preferably, the best one in the ICU would be, anyone want to guess? If you could pick a spot.
Oh, no, go ahead, Julie.
I love this. Okay, so femoral central lines are great in like the previous situation in extremis, right? Because if you miss, the risk is pretty low. You're not going to hit really anything bad in that area. But negatives are the location of it. It's close to dirty areas, so a lot of people think that the femoral central lines are more likely to become infected. Most recent research does not support that. However, most ICUs still practice that way, so femoral central lines come out after 24, 48 hours. Another benefit of a femoral central line is that you can hold pressure if you do miss and you hit the artery. The best in an ICU setting where you can put in or use your ultrasound is going to be a right-sided IJ. You have a direct shot into the SVC, and it's close to surface of the skin. You can see it, and then you can also still hold pressure. And then subclavians are nice when you have a patient, if you're worried, for example, that like we talk about contraindications later. So if I'm worried my patient has like an injury to their IVC, then I need to put a line up high. I don't want to put it in the femoral vein because it's not getting into the central circulation. So the subclavian can be really nice because it's actually tented open by the clavicle. So even if patients are super hypotensive, sometimes you can get a needle in there and get a line in. Negatives, you can cause a pneumo. Another big negative is it's really hard to hold pressure behind the subclavian, and you can't really use ultrasound. So the three locations, femoral, IJ, and subclavian. If you're in the ICU, you have time, the preferred is going to be your right-sided IJ. So indications for a central line are hemodynamic instability requiring pressors. You need to give hyperosmolar agents, so that's going to be like a 3% normal saline or mannitol in a patient that's a neuro brain patient. You can't get your IV access. You need MTP, so you're going to give, you need to give a lot of volume very quickly. Or I added this one, need for emergent dialysis. That can also be when you need to place a central line in an ICU patient. And then contraindications. It was listed as contraindications, but I'm going to say kinda. These are kind of contraindications because sometimes patients with these things still need access. So your coagulopathic patient who's septic, who needs pressure, they still need a line. So with platelets of 12, you're in there putting in a central line. Infection at your insertion site. I mean, obviously, if my patient's stable, I would never pick to put a central line anywhere that looked bad. But sometimes we get IV drug users and they're everywhere looks bad, but you just have to get access. And then you can, once you stabilize your patient, then you can talk about moving it to somewhere more appropriate later. History of surgical manipulation. If the leg's broken, the arm's broken, avoid putting lines there. And then injuries to structures. So if the IJ's injured, the IVC's injured, or you have a C-collar, you can't take the C-collar off, or a pelvic binder. Those are going to be all kind of things that you would think about when putting in central lines. And then central lines. So this right here is kind of how far you put the central lines in. There are these little markers on the central lines that are in centimeters. And so this will based off location, how tall your patient or short your patient is, how far you push in the central line before suturing it to the skin. So you guys are pretty familiar if you've done trauma. This is our cordis right here, 9 French. French is opposite of gauge. So the bigger the number, the larger the diameter. So this is our cordis. It has a single lumen. So there's only one tube, and it's 9 French. So we use this big volumes, MTPs. for our patients. These are the triple lumens. It's a 7 French, so it has 3 different lumens on it. In this tube too, there's still 3 different lumens all the way down, but this is a lot smaller. It's helpful if I have a patient on multiple drips, because sometimes you can't mix meds. That's pharmacy, that's nursing. I don't know which meds can go together, but sometimes they need a triple lumen because they need to be on 2 different meds, and you can't do it through a Cordis. You can always, this is a little ICU trick. If you have a patient who has a Cordis already in, you can quite literally take this triple lumen and thread it into the back of the Cordis. You don't have to stick your patient, you don't have to do any procedures, and you now have a triple lumen. You have your three ports. And then this right here, this is a trialysis catheter. It looks like a triple lumen with 3 ports, but it is for dialysis. It's 12 French, so these are really big. And then there's a trialysis catheter and a Quinton. Those are both used for dialysis, but the trialysis 3, this one has an extra port on it right here. This is helpful because a lot of times our really sick patients, when they're getting dialysis, their blood pressure drops and they need pressors. So I can give my patient pressors while they're getting dialysis with this line. You need to be really careful when you're putting in the dialysis lines because they are very, very stiff. My intern year, I had a patient, it was a medicine patient, he was a young, like 17-year-old kid. I think he had like Duchenne's or something, but medicine put in one of these lines in the left IJ. Oh, anatomy, right? Preferred is your right IJ, straight shot into SVC. Your left IJ, if you're going to put in a line, it has to make this little curve. So I've seen these lines go literally straight through. The person was okay, but that's why your right IJ is preferred. So this is some anatomy when you're going to put in central lines. So your right IJ, left IJ, and then your subclavians. And then this is your SVC. Do you guys know where you want your central line to be? Mm-hmm.
Right after the SBC goes into the right atrium.
Interesting. Right before it, 1 centimeter above. So if you go into the exactly, yeah, cause arrhythmia. So that's something you want to watch for on the monitors when you're putting in your central lines. Or something you can see if they're too deep.
Exactly where.
Yes. So.
Oh, you got it.
Yeah.
All right.
So this right here, here you can see the lines going in. It's making this nice curve. Here's the carina. And then if you can imagine, you can't see really the SVC on it, on the x-ray, but if you imagine it's right here, here's the carina. So it's saying, what I was reading was 1 centimeter above the carina is a good indicator that it's about 1 centimeter away from the SVC going into the atrium. So you want about 1 centimeter above. So you put in a central line and you see this. You don't want to walk up there really closely and see what you can see. What do you see?
It's not in the right spot.
Look closer.
I mean,
Look like this.
put it on the right spot.
Look where the carina is. We see the aortic canal really well.
Is it?
Yeah, it is at the top.
Where?
Oh,
Show me with this. Show me with this where you see it.
That's the line right there. And
Yep.
That's all air.
Exactly. So a lot of times people will, I wanted you to show me
Yeah.
because a lot of times people will see the scapula and they'll be like, ah, that's a pneumo, this lung's down, but that's the scapula. So point out correctly that there is a pneumo, the lung is right here. big pneumo. What about this? What's wrong with this?
Now it's in the right atrium, maybe?
It's
or-
way too deep.
Yeah, now it's
Yeah.
all the way down.
Like, way too deep.
Yeah.
A bummer. I had a fun, I don't know what happened to it. I have seen people put in, you've seen all, you'll see it all by then, but you know, I've seen people put in subclavians and then they make this turn and go up the IJ instead. So always look at your x-rays, because lines can do funny things. I was gonna include a picture of one going like up, but I don't know what happened to it, but I've seen it before. So what about a Foley catheter? When would you put in a Foley catheter? A lot of times people think we need them when we don't. Anyone know some indications of when I would want a Foley? If you need help, here you go. Yep, neurogenic bladder, sure.
Surgical procedures, certain surgical procedures, we put it in like before the surgery.
Yeah,
Certain.
certain procedures, sure. So certain procedures, if I'm doing inguinal hernia, sure, I'd put in a Foley. That's actually pretty old, old practice. A lot of times you can just pee before. With certain surgical procedures, sure. Long surgeries, sure. But okay, so if my patient is acutely ill, I want to know their eyes and nose. Very, very strict eyes and nose. So I want to put in Foley because I want to know how much they're peeing, because if they're just peeing, things can be missed, and it actually really matters. The urine output really matters. So critically ill patients, anybody that you're worried about an obstruction, if they have bad wounds, you could consider putting in a Foley as well. And then inappropriate uses, like we have ways that patients can pee without Foleys now. Men, there's a urinal, you don't even have to stand up, you know, you can just sit there and pee. They have the PureWicks for women or bedpans, but a lot of times you'll get calls from nurses saying like, hey, patient is incontinent, can I put in a Foley? Yeah, I'm seeing some, no, right? Because you don't, it's UTIs, incontinence. I understand nurses are really busy and we do have a nursing shortage, and it's very hard to keep patients clean, but it's just what's best for the patient is just keeping the patient clean. And then arterial lines. So you put an arterial line for hemodynamic monitoring. All right, we talked about that map. So I want that map above 65. And then it's a lot more accurate than a cuff, like a blood pressure cuff. So when I'm putting in these lines, the most often we'll see it in the radial artery, and then it will show you a nice waveform up on the screen. And then if the waveform looks good, then you can, hey, that blood pressure is real. So it's more accurate than a cuff because you can actually see the waveforms. Nurses set this up for you. They're pretty helpful. But then some things to consider when you're putting in an A-line is your actual map goal. So sometimes you want to allow for permissive hypotension. So if your patient's bleeding, you don't necessarily want to shoot their blood pressure through the roof because any clot, you're blowing off the clot. And then also for neuro patients, it's the opposite. Sometimes you want their map 85, 90. Yeah, I was like, why are you commenting on all my neuro stuff? And I remember going to a neurosurgeon. Okay. And then also the location that you put them. You guys remember an Allen's test? No? Okay, so before you ever put in an A-line on the hands, you should do this fun thing where you occlude the radial and the ulnar artery. You have the patient squeeze their hand until you get all the blood flow out. And then you let go of the arteries. Most hands are perfused predominantly from the ulnar. And so you need to make sure that is true before you put in the radial artery. You need to make sure that their ulnar artery is patent before you put in a radial artery, or else you've just killed their hand. So if they're right-handed, you want to put it in the left hand. Like I said, most of the time they go in the radial. Other places you can put them are the axillary artery, the femoral artery, and I've seen them in the DP before as well. The brachial artery, you never want to put a line in a brachial artery because there's no like anastomotic flow around. So you can cause ischemia very, very, very easily. Our attendings differ in whether or not they prefer axillary or femoral artery. Do you have a preference for A-lines? Femoral, yeah.
Well, radial first. so-
Yeah, radial, yeah, so I've heard, like, everyone's different, like, literally, I wrote it down in my notebook. This attending wants me put in this one first, this attending wants me put in this one first. So,
Can I ask?
Yeah.
why You prefer femoral?
I was just what I'm used to, and then I don't think people access the axillary very often, so I don't know if the level of comfort is really there for most people to try to.
it's
But
like
that-
eyes.
I mean, even a radial artery sometimes is tough till you get it. It's kind of like a bike. Once you learn how to do it and you finally got it, it's easy to get in for the most part. Femorals too, pretty easy because it's just right there, except, you know, in people that have extra weight on them. But yeah, axillary, no, I don't think just anybody does that. You know, like, I just mean like, you know, you guys are a different breed.
Yeah.
Because you have to put them in all the time.
And then like the pros and cons, because the biggest fear when you're putting in an arterial line is that you're going to occlude the artery and then cause ischemia. So, you know, if the patient already has one arm, maybe not definitely put it in the other arm. But
Have you ever seen ischemia for the male?
yes,
Or like an axillary?
arterial, sorry, radial.
So what did you see?
It was just the hand was becoming, they didn't test that they had flow in the ulnar, so it was like becoming dusky slowly over time from peripherally.
So what did you do?
Took out the A-line, called vascular surgery.
Okay, so what did they do?
They called plastics and they did nothing.
Yeah, so I mean, if it picks back up, if it's perfused, you know, color comes back, you know, you've got a pulse, you know, you probably want to do some imaging, you may not need to do anything. But otherwise, maybe a thrombectomy, probably not, I don't know, anticoagulation would, if it was low grade, maybe, I don't know,
Yeah.
depends on the circumstance. Yeah,
It's not great.
the most important thing is recognizing it, right? For sure. So like when you're evaluating your patient every day, I mean, that's something that most people are probably not gonna pay attention to, like what color and warmth and whatever their extremity is based on their A-line, but maybe it should be quite good, yeah, it should be, right?
And then also because our patients are on A-lines because they're hemodynamically not stable, a lot of them are on pressors, so you're also going to want to check their extremities. I have seen way more necrosis from pressors. I've done amputations because of pressors. So
I'm
these are the
surgery right now. We have a patient that going to have an amputation.
had to have an amputation.
Yeah, because of
I couldn't hear what you said.
You could because of pressors.
yeah, because of pressors.
Oh, dang. Yeah, I've seen it. One of our favorite patients my intern year had to have both for both legs. So these are the most common pressors that you will see. I found one chart that when it was talking about like the indications of when you would use each pressor, under dopamine for the indication, it said zombie apocalypse because you should always pick something better. I thought it was really funny. But anyways, so these are the pressors that we use the most, and they all have different indications, different and different effects. And like in medicine, there's not just one that works, so you kind of have to play potions master a little bit. But for septic shock, does anyone know like which pressors we would give typically for septic shock? Yeah, so norepi and typically vaso, we'd add vaso on. But yes, norepi, also called levo. So levo and vaso, those are the ones that we use for septic shock. What about neuro?
I don't know this one.
We use a lot of, huh? You can, so like, yeah, so you can do these for like any types of shock, but we use a lot of phenylephrine for neurogenic, and then cardiogenic. What about cardiogenic? Yeah, dobutamine, it increases your cardiac output. And then, yeah, so those are the different types of pressors. They hit different receptors. They cause different things. Some of them are more likely to cause like tachyarrhythmias. and then some of them are more likely to cause like bradycardia. So you have to look at your patient. You typically start with what you know, have a septic patient, start with levo and vaso, and then you adjust because everyone personalized medicine. Sometimes they can tolerate things. Sometimes you're gonna have a cardiac component. So you just, these are things that you're literally, the nurses are titrating up and down, up and down. And you just figure out what works best for your patient.
So
So,
it's also a good time to like reassess their fluid, their volume status, you know, level of acidosis and whatever else. Burnout, but you know, just kind of like revisit, just like she was saying, going back over ABCDs, like, you know, if you're going to start an oppressor, you want to make sure you're crossing all your T's and if there's no other reasons for needing that. Because unfortunately, a lot of times once you start those, even in pretty healthy, not so sick patients, it's just kind of, yeah, it's hard to come off of them, and it's kind of sometimes like this starting to go this way and not being able to go back up, you know.
okay, so back to our patient, same story, same vitals. They got an x-ray, here's the x-ray. Nothing's been done for this patient yet but this x-ray. What do you want to do? Where do you start?
Or the ABCs or?
All of it. You get this call.
And you guys have a team with you, so you guys start. First thing.
Start with ABCs.
Yeah, start with the ABC.
Okay, so
Start
what?
with the ABC.
Okay, well,
Okay.
Talk to them.
Talk to him. Okay, make sure there's an airway.
okay.
Okay, you get through all that stuff. He does have an airway. He's answering your questions. He's breathing. Like you have vitals up there. He's breathing 19 times a minute. His pulses. There's no disability. On exam, his belly hurts, and you have this X-ray.
That would, put them on fluids.
Fluids? Okay, I'm gonna start helping him out, treating him. Cool. Okay, how much fluid do you want to get? 2 liters. How are you gonna give that fluid?
You got 2 pours in.
Yeah, you're gonna need some access. Okay, so we're gonna get either 2 IVs, an IO, or a central line. We're gonna start some fluid. What else?
It's also is it 92% on 4 liters of nasal cannula?
Mhm.
Isn't that fairly low? Or no, not, is that not
Yeah,
really
fine.
interesting?
Mhm.
So I might like elevate his oxygenation.
Yeah.
Or I guess intubate if it gets really bad.
What else? Hey doc, what do you want to do?
So,
But is there, you're gonna go from 4 liters to
Yeah.
8?
So at what point would you make it, like, is you're on increasing the release, so to how much, you know? should
yeah,
you say
it could
something?
change the nasal cannula.
You have a bunch of like
Yeah,
steps.
there's like nasal cannula, and then I think there's, is it a mask? I don't know if it's a mask.
There was an oxy mask,
Oxygen, yeah, I don't know.
non-word breather,
Non-rebreather mask.
and then you do like the CPAP
Yeah.
masks, and then intubation. So it's down there, and then you go up little by little by little by little, unless like patient loses their airway or something prompts, then you can intubate. But yeah, so I'd probably bump up their nasal cannula a little bit. What else?
I would just do like a quick. Let's see.
They have a temperature, 101.4.
So
So,
antibiotics? Yes. What do you want to do before antibiotics?
or order, yeah.
Physical exam?
Order CBC.
I want some labs. Okay.
Like if you didn't say it, you didn't do it.
Yeah. So you guys got some access, you started some fluid, you got labs. What labs do you want?
CBC did.
Yeah.
Blood flow.
Cultures, UA, lactate, I'd throw tropes, why not? 67-year-old dude, tropes. And then I would get the blood, so then I would start antibiotics after the blood cultures. And
X-ray of his abdomen.
yeah, what about this X-ray? I've been telling you about this X-ray for a minute now. There might be something on there.
Perforation.
There's some air. It got some air in the diaphragm. So he's got air in the diaphragm. My patient is sick.
Can you put it out for them?
So,
Underneath.
You got air right here. There's the diaphragm.
Yeah.
The easiest place to see air is above the liver. Same thing in babies, which is why you do a left lateral decubitus x-ray, because it makes the liver on the top and then the air comes up so you can see the air. So liver above, air is above the liver. You'll see it.
It's really hard to interpret intra-abdominal free air on the left because of the gastric bubble. So that's not really reliable.
But you can, yeah, you can
That's
see it
Oh, the right.
right there. And then something else I would do for my patient is I put in Foley. He's sick, he's in shock. I know he's gonna go to the OR. I wanna know how much urine he's making, what it looks like, the color tells me lots. I put in Foley. With this patient, I think you could argue putting in an A-line, but I would probably not do that then. I would take him to the operating room. So I would establish access, like you guys said, start the IV fluid resuscitation, CBC, CMP, lactate, tropes, blood cultures. I would do broad spectrum antibiotics. I would also get a UA, like you guys said. I put a Foley in so I can get some eyes and O's. Got that chest x-ray. We saw that free air. Start pressors if needed, but I would do the fluid first, but sometimes you need to start a little bit while you're getting that fluid in. I would consider an A-line in the ED, but if it was going to hinder me getting to the operating room, I would hold off on that. And then talking about this patient, discussing whether or not we would need further imaging or going straight to the operating room.
Yeah, it's a situation.
What antibiotics would you use in this case?
That's a good question. I use broad spectrum, Darcy, both from there. So typically my patient's paralytic. I know he has a perforation. His blood pressure is 87 over 59. You do not send unstable patients to the operating room. Sorry, you do not send unstable patients to a CT scanner. They will die. They will die. Always on your exams, they will die. Sometimes there's going to be a patient who comes in and their blood pressure is this. You give them 2 years and they like pink up and they look amazing. You see some air under the diaphragm, but the patient looks great. You may have some time for a CT scan, but your patient's peritonitic. You know they have a perforation. They're in shock. They don't need any other imaging. You're going to go to the OR and you're going to do an X-lab, right?
To be honest with you, it's not common that we get a call about free air and plate films.
Yeah.
Usually they've already done CT. Even if they see the free air, they might give us a heads up and then they're like, oh, I really need a CT and they're on their way there. So.
But I wouldn't send them.
No.
Yeah. And then, so we're going to take that patient to the operating room, right? Needs a surgery, needs an X-lab. Patient's pretty sick. And we have to get some consent. So kind of what I was taught about informed consent for surgeries is like the PARQ acronym. So the problem in the procedure, any alternatives, risks, and then any questions. So a simpler patient, maybe like somebody coming in early appendicitis, I could explain to them, hey, you have early appendicitis. I would like to take you to the operating room to do this procedure, explain the procedure, explain alternatives too. Hey, you have early appendicitis. We could try some antibiotics to see if you get better. That is an alternative. We could try that. I would recommend you do this, but these are your alternatives. Also, alternatives are always to do nothing, right? You can always do nothing. And sometimes patients pick nothing. Risks, bleeding, scar, infection, damage to surrounding structures, death, right? You have to be realistic about that, especially in our actual patient, the guy with the perforation. He's sick. He does have a chance of dying. There's a chance of needing repeat surgeries. We have to think about also these post-operative expectations. It's kind of, I like to, if there's a chance that my patient may need an additional surgery in the future, I always like to tell the family that, or the patient that up front, like, hey, I'm going to prepare you. You may need another surgery. This is why. So if we get there, if you do need that other surgery, it's not because something went wrong. It was planned or it's to be expected, that kind Are you gonna leave the patient open? Are they gonna have a temporary abdominal closure? Are you going to be intubated in the ICU still for a couple days? Am I planning on taking you back in 48 hours? Are you gonna have an ostomy? Those kinds of things, just the post-operative expectations for the patient and the family. So you take the patient to the operating room, you do an emergent XLAP.
Talk briefly about the risk assessment.
Oh, yeah, yes, for sure. So yeah, ACS calculator. It's a great calculator. You go online, it's literally Googleable, and you plug in your patient's information, and it will give you these, like a screen, a printout of all of the risks. So risk of death, like risk of complication, risk of nursing home, like all of these risk of cardiac complications. And it gives you a percentage, like high, medium, lows. And so you can use that to then direct your patient and your family decision making. Unfortunately, though, sometimes we get these patients that have 70% chance of death, but if you don't operate, they have 100% chance of death. So you have to kind of do that. Things that go into the calculator are the age, prior surgeries, how healthy the patient is before, any heart problems, are they on oxygen, do they have diabetes, and are they overweight? Those go into the calculator. And then the procedure that you're going to do also is accounted for by the calculator. And then we use this a lot when we're talking to the family. We had a consult a while ago, a patient in the emergency room, and was perforated, very, very, very sick. The ACS calculator was like 95% chance of death. And then it was like if she did make it, to what end kind of thing. And we kind of used that to help. Unfortunately, she died really quickly, but like kind of, you know, making the decision towards making your patient comfortable at the end of life versus surgery, which can make end of life faster.
Yeah, and she actually died like kind of right when we would.
We're on the phone.
Yeah, like, you know, imagine if that had been a little while later while we're like making induction and kind of surgery. So it's really nice to know that and manage our own expectations of the like right thing to do.
And also, yeah, makes you feel better too if you like know your patient's really sick and then something happens. There's only so much you can do as a surgeon. So you take your patient to the operating room, you did an XLAP, they had perforated diverticulitis, you did a Hartman's procedure. While in the operating room, anesthesia was pretty good. They gave the patient some fluid, blood pressure improved on some minimal pressors, not a lot, minimal pressors. So you made the decision to, you know, bring up an ostomy and to close the patient. And then you transferred him to the ICU after surgery for continued care and further resuscitation. So when you send your patient, I thought this was like a silly picture, but I really liked how they laid out the mnemonic for you guys. So that's why you got it. So when you're putting in your ICU orders of ICU patients, these are all the things that you need to consider. So feeding, how are you feeding the patient? Are they getting PO intake? Are they getting a TPN, analgesia, can't speak, you know, pain medicine? Do they need sedation? Are they intubated? Do they need like fentanyl, propofol? Their DVT prophylaxis. Are you starting them on it or are you holding off on it? You're going to also head of bed elevated to 30 degrees, help prevent against aspiration pneumonia. You're going to give them GI prophylaxis, which help prevents against ulcers, but makes that aspiration pneumonia risk higher. Glucose control in the ICU. Do you guys know what you want your glucose to be under? Under in the ICU, sick patients. You guys haven't you guys done this yet? It's like my favorite pimping question on rounds. 180. 180. So when patients are sick, you allow for permissive hyperglycemia because in the acute setting, what's going to kill you? Hypoglycemia. So you allow them to be a little bit higher than low. So under 180. Sweet sugar. I call it the wrong thing. It's either sugar trial or the sweet trial.
Yeah, and that came like after my residency because we used to keep them less than 100.
Yeah.
So yeah, weird,
It's a
you know.
weird switch. It's called the sugar trial, I think. Sugar or sweet, I don't know, one of those,
That's fine.
but under 180.
In IM, they like between 140 and 180. Is that like the sweet spot or it's like
I just like
Or
it
is it
under
just
180.
under?
It's under 180. Not hypoglycemic, but under 180. And then spontaneous breathing trials. So it should be done every day unless your patient is a brain patient who you're keeping down, or an ARDS patient who is paralyzed. But you should be doing spontaneous breathing trials every single day. So that means taking your patient off of the sedation and putting them on pressure support and seeing if they breathe on their own. Bowel regimen, and then
What do you mean by that?
so for that, are they pooping? Are they constipated? We often forget that our ICU patients still need to poop. So are they getting like Miralax, Senna? They should be still pooping regularly. If they have wounds, you guys will see those, the Digna shields or the Flexitubes, Flexiseals. We don't love those as surgeons because those can actually cause rectal pressure ulcers on the inside. But sometimes, like if you have neck fast, what's the lesser of two evils? So you're gonna put in one of those tubes, and then also like ostomy stuff, which we'll get to like the next slide or two. Does your patient have lines and tubes? How long do they need the lines and tubes? When can they come out, and where are they? How long have they been in? Our new Epic will show you right on the side, if you have seen it, all the patient's lines and tubes. It's really nice. It'll show you where the IVs are, show you where the central lines are, and when they're replaced.
So best practices in terms of lines and when they should, how long they should be in?
IVs.
Well, IV, well, yeah, we're gonna include that, but I was talking about like central lines.
As long as they don't need it, then you take it out. If it's dirty, you need to give them a sterile line. And
What do you
then,
mean, how do you know?
because I put it in, if it's not sterile, it's dirty, right? So if it's done in like a crash situation, I'm not sterile, the patient's not sterile, it's not a clean line, so if that's dirty, that needs to come out. Sterile lines, I don't actually know, like 2 weeks? But you want to get them out as soon as you can, pretty much, right? So as soon as they don't need them, you take it out. So that's something like you're actually thinking about every single day. Like, do they still need the A line? No, take it out. Do they still need the central line? No, take it out. And then let's say they no longer need pressors, but the nurse is using the central line for the fluids. Okay, now it's time to get IV access. And once we have IV access, the central lines come out. But just as soon
And
as
you have
we
to think about those things, because the nurses love those lines.
Yeah.
They're not gonna say, hey, can we put a peripheral IV in? No, rarely. Sometimes, but, so. Next thing you know, your patient will get a low temp, lights out, count starts climbing, you're not sure why, and interestingly, like, it's easy to forget about those lines, the dirty lines that are in. I mean, sometimes we're working people up from top to bottom, why they've got like a white county fever and fine, and like the last thing people think about a lot of times, so.
With your sedation, whenever you have a sedated patient.
Yeah, so SBT and spontaneous awake trials, SATs, at the same time. And then you always want to have the patient as awake as like they are comfortable. So you want them to be as awake as possible while keeping them comfortable. There's no reason to snow a patient unless they're brain or arms. But if you have a patient who's just intubated, they should be arousable still. They can still answer questions and follow commands. But yeah, you would also do a sedation holiday as well. So these are the most common drains that you'll see. Top one's just a JP drain. You guys have all seen that one, probably taken it out before us quite a few times. It looks like a grenade. Something that I see a lot is that it's not squeezed like in, but somebody will take the bottom and push the bottom in, and that's not on suction anymore. So if you see that, just a fun fact, not on suction, physics. It needs to be like this, has a stopper on top. That's where you empty it, and then you squeeze it, and then put the stopper back on top, and then allows you a small amount of suction, negative pressure. Every day, we typically strip these drains. You see us grab the hand sanitizer and pull to get out any clots or things that could cause them to be obstructed. These bottom two right here do not have suction associated with them. The one on the left is called a Malatot. It's this tube. It's a tube, and then it has like a little mushroom on the end of it. Typically, we put these in like abscesses or cavities we want to keep open to allow things to drain out. Same as the Penrose. No suctions involved in it, but it helps like if you have a tract or a cavity that you need to keep open to allow things to drain out. And then both of these things are like a tube. Sometimes you keep it in and then slowly take out to help like for healing from the depth to the surface. And then you have the NG tube on the right.
One quick thing. So if you empty that JP and then just retop it and don't squeeze it down with the grenade and then close it, then it's not on closed suction. It's not constantly pulling stuff out like we want. Also, make sure you're always holding the proximal. It's like if you were combing hair, like so you can pull as hard as you want with the stripping as long as you're holding proximal. If you don't do that, then you can pull the drain out. Or it'll just really hurt. The other thing is, a lot of times you're like really trying to get that. You see like the little worm inside the tubing and you're like trying so hard to get it out and it just it seems like it's coming, but it's not. Because it's on closed suction, like just the fact that you're stripping it and getting it even a little further down, with that constant closed suction, like you may come later in the day and see a little worm in the tube. So you don't always get it all the way out. Just keep that. I mean, it's nice if you can, but you know, the closed suction of it really helps.
And then NG or OG tube. This right here, I saw an NG tube this week. Suction was hooked up to this port. This right here is not where you hook up suction. This is a sump valve that allows air in to the tube so that the tube doesn't get stuck up to the stomach wall and cause an ulcer. So this is where the air comes in to let the tube off of the wall. So NG tube gets hooked up to wall suction from this thing right here. Typically, we put NG tubes to what type of suction? Yeah, low intermittent suction.
Yeah. What's wrong with low continuous?
Well, some people do that now too.
Yeah, but I mean, your thoughts.
Hypothetically,
What?
What's
Why?
the question?
why? So typically, we put NG tubes on low intermittent suction. So what?
From sucking on things.
Yeah, exactly. Mhm.
Did not hear it all?
Yeah,
It just started or?
it's been going on for 15 minutes.
Oh, well, the video. I mean, the video started it, right? Okay.
I would just, yeah, we can be here and then just.
I feel like there's gonna be a go. I can't. I don't know how to.
Turn that sound off?
Speakers here and then mute yourself on there and then keep this on like on the Stephen Evening. The what?
Oh, next.
You. I did. We made it, but it's just coming from the, like, from Jonathan's. Like we're using another phone.
Can you not turn off the sound?
go to the T. No.
Sorry.
Next people that come, they're gonna be like, stuff because they're not gonna realize it goes down on the actual TV.
Sure, we'll just put it. That was pretty cool.
There you go, that one. Whatever you just hit was the sound. Cool. Oh, no.
Hold on.
So our patient had a Hartman's, so now we have some stomas.
What is a Hartman's?
These are a great question.
Like the, cold, like. Cold loss.
Yeah, and the last.
Thank you, loss.
Yeah, so on this,
They went down there.
Or that's part of it, maybe.
if this were like a whole colon right here, Hartman's, you cut like here, and then whatever's bad, like here, staple this off, and then this part comes up as an ostomy, like all of this, then gone. So there's a bunch of different types of stomas, an end, a loop, or sometimes you'll even see patients with two. From the inside, this is what an end looks like. So just pulling up a tube, and then suturing it to the skin. So it's an end, and then this is a loop. So typically what happens is like poop and stuff can come out, but then it doesn't really go back in. But then what can come out of this is any like buildup of gas or mucus. So similar. Yep. So for example, like right here, or for an end versus a loop. So end versus a loop, typically what we do the most is a loop ileostomy. So if I have a patient who, for example, had a Hartman's, and then they come back and I'm able to put them back together. So I'm able to connect the colon to the rectum, do that anastomosis. You could bring up a loop ileostomy of the ileum to protect your anastomosis. So poop doesn't ever get over there. It comes out before then, because the loops are really easy to reverse as well. You don't even have to go into the belly. You can do it all extracorporeally. And then sometimes you'll see these two, like this. So I had a patient who, something happened with a transverse colon. They had a tumor here or something, and I needed to help get poop out. So they have an end ostomy on this side. But if I were just to leave this stapled, this is a really long limb. So a lot of times you end up bringing up something called a mucus fistula here, so that the pressure doesn't get too big in this section and get dilated. You can get and like stuff can't get out. It increases your risk for bacterial overgrowth as well. So your end, your loop, or sometimes you see two. You can also have an ileostomy, which is of the ileum, or a colostomy, which is of the colon. And then you can further have descriptors of ascending colostomy or descending colostomy based off of like what part of the colon there is.
What's a mucus?
So a mucus fistula is where you have like a long segment like this that you want to decompress. And so it's an ostomy, no poop is coming out of it, but it's an opening. Yeah.
Like stuff. So can you still have a bowel movement if you have?
You guys think so? Yeah, I guess I should ask them.
Or we define bowel movement.
Yeah, through the ostomy. Or the, like, it's not gonna go through the prep, like.
Will you ever get anything out of rectum? Shouldn't?
You should.
Everyone agree?
Shouldn't.
Rachel, do you agree? Ro?
No, I think you should. It should still.
Oh,
You
yeah.
could-
Say again.
Like mucus.
Okay, good. What else? Yeah, so like you can have retained stool, like we didn't like wash them out, right? So they could have a whole bunch of retained stool in there and have poops coming out of there. So it's not like active functional bowel versus peristalsing all the way through because it's disconnected. But it can freak people out, you know, so it's nice to warn them. They might get a little something. Even the nurses don't understand that. And it could be mucus. There might even be a little bit of blood because we kind of messed around in there. So just FYI. And then I'm so glad she mentioned one thing that makes a resident look really bad. You have to be super careful. The patient will be like, yeah, I have this colostomy. And so everybody's writing down colostomy, but it's an ileostomy. Or, you know, like if there's an op note to be read, read it so you know what they had. Don't call something an ileostomy and it's a colostomy and vice versa. And if you're not sure that you say some type of ostomy, I think it's in the right lower quadrant, most likely it's a ileostomy, right? So just kind of keep that in mind because like, you know, once you're in residency, you're kind of like a higher level, right? You're not just writing down anything. Okay.
And that's like attending's favorite question is if there's an ostomy, what is that? Always. Always. So here are some different stomas. So this one is, this is the same person. This is a new one. You can see it's a little bit protruding. This is like a mature stoma. It protrudes a little bit. It's pink, it's patent, and it's painless. Those are your P's. This is a new. So a lot of times you get called because it looks a little bit dusky, but it's normal for a new ostomy to look like this because it's edematous and you'll get some venous congestion. But it gets better and it eventually turns to look like this. But when you're examining this every day, a lot of times you'll see us like stick our finger in it because we're making sure that it's patent because the new ones, they can kind of get stenosed. And then, but this edema pretty much, it will go away and eventually most time looks like this. Sometimes if you have an ostomy, even if it's mature, it will fluctuate. So sometimes it'll stick out a little bit more and go in a little bit because in essence, like it's a kaleidoscope type thing. It can move.
And that
But-
can get incarcerated.
Yep.
Very rare, but you would know it. It'd be purple. It would look like that whole thing out. It'd be kind of like if you had a rectal prolapse, similar look.
And this, yeah, so this is a prolapsed ostomy. Yeah, I had whole guy's like colon prolapsed out. So prolapse is, like you said, can become ischemic. This is dangerous. This can, but if it's not ischemic, something that you can do to temporize it is similar to the rectal prolapse, is like the osmotic stuff. So you could use sugar if you're not worried about ischemia. If you're really not worried about ischemia, you could attempt to reduce this with sugar. This is bad. This is necrotic. What you need to worry about if you see a necrotic ostomy like this is you need to make sure that the necrosis does not go below the level of the fascia. So you can stick a test tube in here and it can kind of give you a window deep into the stoma. And then, or you could actually stick a scope in here even to see deep into the stoma. If this necrosis goes below the level of the fascia, that's a surgical emergency. If it's above, you got some time.
And so the theory with the test tube is like you're putting it in and you're gonna put a flashlight, or I don't think the
You can
iPhone,
see it.
yeah, you wanna reflect it to see. And you'll see like, just, you know, maybe like an inch in, it's looking more like maybe the left lower
Yeah.
than that. And then, so you know that this is just surface level sloth or even ischemia, but you know, it's not like propagating more proximally. which
And we
could be a
actually,
problem.
we have to do that a lot because sometimes the early ostomies, the venous congestion can look a lot like
Look
ischemia.
like that.
They look gross, they look bad until they look good.
What would you do in that? Monitor and just
If you venous congestion, you monitor. If it
Completely heals. Yeah, so
This is
monitoring.
retraction. That's stomal retraction. And
So when you're documenting every day on your notes, like she said, pink, viable, patent, and you also want to record the output, not a volume, but was there gas in the bag? Or at least be able to report that to your senior, because that's all they care about. All we care about, was there gas? Is there still sweat? Is there now a little bit of succus? You know, is it still just flat? So that you want to always make sure to record that as well.
yes. And then this is a peristomal hernia. So when you're bringing out an ostomy, you go through the fascia, you go through the rectus muscle. So you violate the fascia, you always have a risk of a hernia. And so this is what has happened with the peristomal hernia. Same thing as other hernias, you fix them with the same like elective urgent emergent based off of obstruction ischemia, all that. And then nutrition. So you always want to start nutrition as early as possible. People can typically go about 7 days without nutrition. Whenever you're thinking about how to feed a patient, enteral feeds is the best. You want to feed those little cilia things, villi. And then enteral feeding is preferred. And then when you also feed enterally, it helps prevent against the bacterial overgrowth, which can then lead to bacterial translocation. And also TPN sucks and it has some long-term complications like terrible fungal infections. It's also bad for your veins. It's also really, really, really expensive. It's just not as good as eating food. If your patient can't swallow or they're intubated, but you can still feed them enterally, so you're not worried about their stomach, their intestines are all put together. They're just still, cognitively still sick and asleep. You can feed them with an NG tube or a Dobhoff. Difference between NG tube and a Dobhoff is NG tubes you can feed, give medicine, and then also decompress, so you can suck. But the Dobhoff is a smaller lumen, so you can only put things through it, down it. So for feeding, it's some meds. Some meds, unfortunately, you also can't put through the Dobhoff though, because they'll get clogged. And then the article that I read for this one said that if it's going to be about 4 weeks or longer, that's when you want to consider a surgical feeding access. So a PEG tube, a G tube, which are both tubes in the stomach. The PEG tube has a bumper on the inside, and a G tube is a balloon on the inside. They are the same, they're just different tubes.
And another thing to know, right? When you're an intern, sub-I, gastrostomy or PEG, right? It's kind of doesn't matter, but it does. I mean, it actually does matter a lot.
If I change it, I want to know what.
Right, it actually does matter a lot, but it also just kind of looks bad when we're calling something like a G tube and it's a PEG. Because it does matter.
Mhm.
It just changes differently. The time interval of when you can change it is different and everything else, so.
And sometimes a J tube, which is pretty much the same as a G tube. It's just in the jejunum. Those are gonna be for long term. So 4 weeks or more. These are not without risk. Always counsel my patients on the risks. I've seen people die from PEG tubes being dislodged and feeding the abdomen. Seen it all. There's things to think about, especially. Sorry, another ethical question. That's the ethical place, but like, does your patient have a chance of recovery? Like, what to what means? And then TPN, PPN, you can use this if you can't feed them entirely. PPN you can put through a peripheral line. TPN needs to go through a central line. And then refeeding syndrome. A couple years ago, there was a patient that died in the ICU from refeeding syndrome because it went unnoticed. So typically, like when you start feeding patients, you see this a lot with alcoholics who are have poor nutrition for a long time. But once you start feeding somebody at day 4, you start to see these electrolyte derangements. You want to pay attention to the potassium, magnesium, and phosphorus. Sometimes you're getting BMPs as often as like Q4 hours with electrolytes. Q4 hours and you're repleting. Because you can cause cardiac dysfunction, profound weakness, encephalopathy, congestive heart failure, and then also failure to wean from the ventilator. Causes a decrease in ATP, and then how you prevent it is you start with slow foods, so 10 to 15 kilocalories per kilogram per day. You go slowly. There are calculators you can use that tell you how fast to ramp up the tube feeds, but also your friendly dietitian.
This is a question that they like to ask from time to time. Very like random thing that I don't think I've ever seen it.
Oh, the question or me?
Yes, refeeding syndrome. But I mean, like they do,
The question.
but I mean, now that you've seen that, you know it, like it'll kind of click. I don't know, maybe I missed, did you talk about the bumper?
The PEG.
Yeah.
Yeah.
So that's gonna be an important job for you guys when you're rotating, because literally that bumper or the dislodging or the full backing or the change of that can cause like it's pulling away from the abdominal wall, and like she was saying, like the potential complications that, PEGs and G tubes are phenomenal, but like when they have complications, I mean, imagine having to take someone back because they got fed in the abdomen, or because they've got this bad infection down the whole G tube site down through and through the fascia. And now the hole in the stomach's super big and enteric contents is coming around it. So something as simple as that bumper, like keeping it affixed to the abdominal wall until it scars in and heals and creates its own tract is super important. So it's something you should be checking every day, because I'm telling you, like, you will fix it and then come back there 6 hours later and, I don't know if the nurses messed with it or the patient, like, and it's on a fresh G tube,
Question, is the G tube the same as the O?
No, so an NG tube and an OG tube are the same. It's just whether or not it's in the nose or the mouth. Yeah. A G tube is more similar to a PEG tube. It's a tube in the stomach that you use to feed the stomach. So it goes into the stomach and then out into the world.
Yeah.
But a PEG tube has a bumper on the inside.
Is that the only difference?
A bumper versus a balloon. Yeah. And typically how you put them in is different. PEG tube goes in with an EGD scope. Because then that's how the bumper gets there, is you pull it through the mouth. And then a G tube, you can put in open or laparoscopically. Just like put it into the stomach.
How do you monitor the nutrition level? Somebody who's on like long-term feed. Anything in particular you check? Lab-wise, maybe?
Albumin levels.
Oh, I think I heard someone online. Oh, close. Very close. Pre-albumin? Yeah,
Right.
it's a shorter term. It tells like the more short acute term nutrition. Albumin's more over a longer period of time. Okay.
And then, the reason I sent over the older version of this to myself, but DC planning. So you're thinking about discharge planning. This starts when the patient's admitted. You start thinking, you get case management involved, you get social work involved. you're gonna consult PTOT when they're here, and then PTOT will evaluate the patient and they'll tell you, they'll give you guidelines of whether or not they're thinking acute inpatient rehab, like Schwab, or a SNF, skilled nursing facility, or a nursing home. Those are the three different things that you would go to. Like nursing home is grandma, just needs some help, can't live by herself, but she's not very sick. Skilled nursing facility is, you get your sick grandma, maybe has some tube feeds and some antibiotics and a trach. And rehab, those are the people you're expecting to be better, become better, like get stronger and then go out into the world. And then things to think about, are they gonna need home health? Does our patient has an ostomy? So we're gonna get social work involved, we're gonna consult home health, get all the supplies for the patient's supplies, that your CrossFit teaching, do they know how to change? Is their family there to help them? Do you have a wound that needs managed? Long-term feeding, can they eat? Do I need to set up for them to have tube feeds? Do they need antibiotics? Any discharge medicines? A lot of times our patients are gonna have new meds going home. Whether or not we've done surgery on their stomach and they now need like protonics, PPI, or we've done vascular surgery, they need aspirin, statin. A lot of times we're giving patients like new prescriptions and follow-up appointments always as well too. Like, who do they need to see? They need to go. Our patient had diverticulitis, GI. Like, who do they need going forward? Do a diagnosis. I have a bunch of questions on my other PowerPoint, but this is not it. I can pull it up.
Yeah, pull it up. While you're pulling it up, I'll start.
Yes.
So let me ask two questions. How do you know if somebody has urinary retention? Oh, that's one of my questions. Huh?
Can't you press?
Wait, bladder scan. I mean, like, does everybody have bladder scan just at their like fingertips? Yeah, so yeah, first you can palpate and, oh my gosh, no, that wasn't our case. We had a patient the other day, young guy, it was a lap appy. And when I was sitting in the little stool in the OR while he was being induced, and I'm like, 'cause he's like a thinnish guy, and I'm looking at him and like his infraumbilical area, the whole lower like pelvis to umbilicus was kind of like just like pooch. I was like, wow, he's kind of distended. I think he may have ileus already. Then we put the Foley in. He had 2 liters of urine. That was his bladder. Yeah. So anyway, yes, it's important to palpate. And then if you need to, obviously you're going to check how much urine outputs, and you can do the bladder scan would be like a great thing if you have or that is accessible to you. Taryn, intubation, like what are kind of your endpoints of when you want to intubate?
When do I want to?
Yeah.
Like altered, once they're becoming, they can't protect their airway. Like gargling,
That's the biggest thing.
everything. Obviously, I have a low threshold. It's always safer. It's always a safe thing. Unless they're BCSH or they're like altered, so they're gargling kind of thing. If they're protecting their airway, you can feed them, but you also watch them. And then things to also think about if their blood pressure is super, super, super low, but you're not like an emergent airway, but you need to intubate them, you actually want to wait until you're in the operating room, because if their blood pressure is super low and you push meds to intubate, they'll crash.
The other thing is, if somebody is like, let's say she was saying like they can't protect their airway, but they're partially protecting. Well, see, this is a different environment. We're in a trauma bay with a whole bunch of people, or in the ER where it's kind of like constant, person there, or ICU. But imagine if someone's crashing on the floor and they're kind of like waxing and waning level of consciousness. Kind of, you think, okay, well, I think they're protecting their airway now. That's not somebody you just want to leave like that. Because that's what you're hearing overhead all the time, right? Because unfortunately, there's just not people in and out of there enough. So either transferring to another, it sounds like they're going to need to be transferred to a higher level care regardless, but some type of airway protection, that kind of thing. But yeah, probably escalating at least their care in the meantime. Okay, we're going to do this one. Oh, did you get them? Pick one. Okay, read it aloud for us. Everybody can still hear us? Just have a few questions and we'll be done soon, guys.
Okay, I put it on speaker. Okay, I'll try. Your patient that you ordered a CT with PO and IV contrast on due to worsening abdominal pain has a creatinine of 2.3. She wants to know if you still want to do like the IV contrast. So a doctor talked about this with me, but I don't remember exactly. I think if they have abdominal pain and something is really wrong and they're in the ED, let's say, sometimes they overrule like the 2.3 creatinine and like the IV contrast and they'll still order it with contrast.
Is there
But I
any
don't
other
know.
data you want lab-wise to help you make that decision?
Maybe BUN.
Which helps you calculate that?
GFR.
Yeah.
The GFR.
Can you make them up so we can hear them?
Yeah, they're on speaker now.
Oh, they are? Okay.
Yes.
I think we'll hear it. Yeah, so we were actually just talking about this in M&M this morning, like, it's kind of controversial. I mean, generally speaking, you don't want to be the one to like tank someone's kidney all the way over the top. So sometimes oral is enough. It's just a clinical decision. Usually we're gonna probably err on not doing it, but if somebody really needs it and their GFR is above 30, 35. But I think at your level, intern, resident, I would still be asking my attending, and I wouldn't want to just say, yeah, overrule, go do it. And then because medical legally, that's kind of on us now, right?
Yeah.
So if you don't really think it's indicated,
Yeah, the attending said always ask the attending. It was
Yeah,
like
I
the ER
think
attending. He's
that's
like
a-
always ask me or the attending if like you're in the situation and they like call you or like you're there. Yeah, that's what he said.
If your patient's already on dialysis.
Yeah.
oh yeah,
You can't kill kidneys more.
No. So you can do contrast.
yes, and thank you for mentioning that's a real good.
But you see it all the time. Sorry,
Oh,
you didn't,
Yeah.
the kidneys. Oh, the kidneys are already gone.
Oh, that's already, yeah, that's right. And they might need something else. Might be gone. Gotcha.
So
Go ahead.
Okay, so I didn't know. When would you be able to give a bolus before that? Would that be like a good indicator to give them like a 500 cc bolus before they go in and get IV contrast?
Thanks for mentioning that. Yeah, they have protocols at different hospitals that are boluses and other things. If you're gonna go ahead and give IV and they have like a decreased GFR. But that's not gonna just be an automatic. They're gonna make sure that you are giving permission to do it and it's on you.
Yeah.
But it may help, it's not a bad idea. Do we have a protocol here with that?
No, but like sometimes for our vascular patients, you just need to you can't, because for a vascular patient, a CT without contrast doesn't help you. So a lot of times we do end up having to give contrast and the kidneys do take a little hit, but we do prehydrate them. But there is no set, this is what you do, this is how we do it.
And it's also a good time to like reevaluate other stuff. And I once was aware of a case outside of here where a young woman came in like septic and, acute renal failure. Then she got a CT with contrast and then another CT and then like VANC. And
Oh my
there was
gosh.
something else very nephrotoxic. And she literally went like, her kidneys like failed.
Oh.
She had to get dialyzed, etc. Thank God she did eventually come around, but it did not happen right away. And it was all like iatrogenic to some extent. Like, I don't think a lot of that was super necessary. Like the VANC was super therapeutic, for like, wasn't recognized for like, 18 hours or something. It was just kind of like pile on.
Yeah.
Yeah. Okay.
A 70-year-old woman presents to the emergency room in atrial fibrillation. She has an altered mental status, a blood pressure of 70, and abdominal distension with pain. How would you work this patient up? What would you like to know? Well, first I would start with the ABCs. And after that, I would like to get IVs in there to try to get some fluids in there. Then I would like to try to get some like, some histories, past medical history and stuff like that. Because when I'm seeing atrial fibrillation and abdominal distension, I'm possibly thinking like possibly like occlusion of a GI artery or something like that. That's possibly
Okay.
causing
And what would that cause?
the pain. What do you mean?
pain, but like what?
Ischemia.
Yeah, ischemia, yeah.
Of,
Yeah, that's bowel, yeah, bowel ischemia.
great, awesome, good job. Okay, so I think one lab would be very helpful for us. Anybody?
Like to,
Yeah, good, guys, the same thing. All right, that's what I was getting at with that one.
Okay.
We don't have that much. Huh? So we pay attention to those. You're gonna have you like. Basics. Mo looked very excited. Did you see that look? He was very, very.
Your patient had a small bowel resection 3 days ago. He's tolerating clears. He's asking for more pain medication and as he has a lot of gas. What is your response? More pain. Bowel resection 3 days.
Nurse call.
He's tolerating clears. He asks for more pain meds. Why not?
Really?
What is your
You're like, you said, why not go ahead? You go back.
3 days?
The one with the D is my favorite. Yeah.
When they're telling you. which one they want.
I mean, I know,
We're asking for the Michael Jackson.
so he hasn't had a bowel movement. Is that what it's saying?
What do you want to do?
I need to go see him and
Okay.
see, but
Thank you.
go see him.
That's.
Wouldn't you want them often less because you want to prevent post-operative,
Excellent. That's important. And also just making sure there's no like change in clinical status or escalation of something like, subtle that's starting to brew. Because like, oh, I'm having gas. A lot of times that's what they're saying. No, I'm just gassy. And you go in there, the abdomen's like here and it's super tender and rigid. And you're like, they're a little tachycardic. There's something might be brewing. And then again, it could just be ileus, gas, or just some post-op pain. So, but you don't want to just say, okay, and turn back over.
Is there a difference between being gassy and having gas? Yes, right.
I think
Because
a lot
you
of
can be
times-
like descended and still be passing gas and that's okay.
Yeah.
no?
A lot of times it's just the way patients characterize their
Yeah.
discomfort.
Okay.
And they'll a lot of times you'll hear them just say, no, it's just gas.
Yeah.
I just got gas. And it's not that,
Yeah. Okay. That's interesting.
Maybe we should get a question for someone.
Yeah, we're gonna get everybody. Don't worry. We still got like 15 minutes.
Okay. You are called to see a patient who is PO day number 2 from a small bowel resection. She is in the hall being disruptive, demanding to eat, or she will leave AMA. You were signed out this patient. What information did I get in sign out?
Okay.
So I guess I'll just go see the patient, see what's going on, and then plan from there.
Okay, good. So how are you gonna approach the patient?
Well, first off, if I am an intern, then I will, of course, be like, okay, so I got sign out from the team that was taking care of you previously, and I want to know what's going on. Like, I hear that you're wanting to eat and it's 2 days, and then ask her how she's been tolerating her previous diets that she's been on. And
Does she even know what tolerate?
Oh, well, of course, I'll be like,
that she's gonna eat, right?
how have you been eating? Have you been taking your liquids okay? Like all that.
Yeah, so I mean, I think just a lot of times, especially when they're in that kind of mental state and mad and whatever. I mean, just listening, trying to explain in layman's terms as best as possible. A lot of times they just are frustrated and they just don't understand. So yeah, but going to see them is the most important thing. Not necessarily relying just on a sign out that may not really have much information. Because you don't really know why they're still in PO or just on clears, right? You need to go figure that out.
Yeah.
Okay. Many people are still hanging on. Can you see?
Still on. Probably can. The nurse called. Your patient had a low anterior resection for a low rectal tumor yesterday. He is now very constipated. Nurse calls to confirm the order your co-resident put in prior to sign up for a suppository.
What's the question?
So whether or not the nurse wants to confirm the
The suppository.
the suppository order. He's constipated and he just had a lower anterior resection for a low rectal tumor.
Does he need, like,
First of all, oh, he's this is post-op day one.
I think so. Is that what it says?
It doesn't say.
Oh, okay.
Yeah, it does. Yesterday.
You can ask one of your colleagues.
I'm just
Wait
like
3
wondering.
days.
Would you go see the patient yourself, even though because the co-resident ordered?
I mean, I'm never gonna tell you not to go see the patient and sit and go through the chart and all that, although you can kind of do that remote.
inferior?
It's an anterior.
Low, yeah.
Oh, do you guys know what a low anterior section is? Maybe
I try to
that's,
bring it.
that's basically taking out
Isn't
like,
it out of your butthole?
yeah.
That's above the butt.
You-
Above, you still have
Yeah,
the.
you still have butthole.
You still have it, but
Right, scientific term.
the stapler and stuff is going through the anus because usually it's very close to the anal verge. So the anastomosis is done like, yeah, like a couple inches from the actual anus.
Like from the inside, you are as low as you can like get.
Yeah.
But don't you also wait like 3-ish days to see if they have a bowel movement?
So the answer, do you want to give them the suppository?
No.
No.
Okay, why?
Because A, there's not enough time for them to have a bowel movement. 2, their butt will not
Still.
gonna be able to
Yeah.
take it.
Do you want any?
Operated on.
They can-
It's just-
Because you. Yes, it was literally just operated on painstakingly. And wow, things can definitely happen, even without putting anything up there.
Yeah.
So, okay, so no, nothing per rectum, right?
Mhm.
And always consider that when you're getting called and you're sleepy and you're like, can we just give them suppository, they're constipated, look at your list. If you can't remember what they had or whatever, you might wanna.
Yeah.
All right.
Can I ask a sub question of this?
Is this a patient you would have put a rectal tube before?
No.
No, that's like the same exact thing. Like,
So
you
you
don't
get
wanna
it there.
stick anything up there. It was
Okay.
just sewn or stapled together.
Okay.
Constipation, could we
That's
just like,
a question.
yes, it's just like very.
So you're worried about the constipation. He's just post-op. He's got
Yeah.
ileus. He had a bowel prep.
It's gonna be
Like,
uncomfortable probably.
Hey, no. She literally already answered this question in my talk.
Yeah.
let's see.
Fine, I'll do
Okay,
another
get
one. I'll do another one. It was the what's the best fluid for resuscitation?
Oh, you sure did. Literally.
2 points. Why is it important for a post-op patient to have an incentive spirometry? Spirometer. So you want to work. Oh my God, I just remember answering this question. But essentially, you want to increase positive pressure in your lungs.
Yeah,
So
so
want
when
to
you
make
get
sure
those,
that
they
they collapse.
lower.
No, they suck on it. They suck on them so that they can expand their lungs again. Because post intubation, you tend to. There's
What are they trying to get? It's like
atelectasis.
Associated.
You will.
Atelectasis, yeah. And the other thing that happen a lot is like people who have like, sorry, funds now. Sorry, I'm just like imagining them like running down the halls, like, okay.
What are they gonna find?
Anyway, yeah, people with abdominal pain, abdominal distension, abdominal wounds, like the tendency is like,
Yeah.
and so the lower parts of the lung kind of collapse and get atelectatic, and then like it can breed like 4 pneumonias. So that's such a tiny little thing, but it is important. Okay, who's on line? Pick one for someone on line.
Rachel still on.
Rachel.
Can you guys hear me?
A sound left
can
in
hear
here.
you.
Next question? Is this serious?
Okay,
should
so
text him.
Rachel, what are the recommendations for DVT prophylaxis for surgical patients?
Oh.
For surgical what?
Patients.
You can use the compression devices. You should put them on before you go in for an induction to help with DVD prophylaxis. You could also use compression stockings.
That's it?
What are we talking about?
DVT prophylaxis.
Oh, well,
Lovenox.
Heparin.
Oh yeah, yeah.
So
Lovenox.
just
Coumadin.
maybe for some people or?
They usually do it for everyone.
It's for everyone.
Yeah, it's a big
Everyone.
deal.
Oh.
People used to drop dead after like just routine surgeries because of DVTs and TEs, right?
I remember Layla getting on for an incident, right? Or it was an intern rotating here.
Yeah.
see a real doctor. I was like,
Uh-oh.
Poor
Yes, you
guy.
gotta make sure. It's malpractice if you don't write for that, perioperatively. So.
But you hold it for surgery.
That's
That's
part
what I
of
thought.
your.
So
You hold
we
not
actually-
hold it?
So general surgery here
Yeah.
does not hold DVT prophylaxis for surgery. Plastics, neuro, ortho, they will.
Okay.
We do not. Often we are actually operating on patients who are anticoagulated on purpose, like all of our vascular patients are anticoagulated on purpose. And then we will give, for complex laparoscopic surgeries, you actually give heparin before surgery.
Interesting. Okay.
So all of our bariatric surgery patients are getting heparin at pre-op.
Okay.
Okay, we got 3 minutes here. Rachel, you answer one more for us. You can do something fun.
What is the best fluid for maintenance IVF?
Oh,
Have a sec.
well, that's maintenance.
Yes, maintenance IVF.
Rachel, do you hear that?
Yeah. Is it NS, normal saline?
Do you agree?
No,
Okay.
The lactated ringers.
no,
No,
D5.
we said maintenance, not bolus.
Oh,
So remember, bolus was LR, mate
D5 has
with,
With potassium.
yeah, how much?
Potassium. I don't know.
the equivalent.
40?
I can't
That's
compare.
20.
Come on, you guys.
20. Yeah. You don't put that.
You should know that.
If you give too much potassium, it could be bad too.
Yeah.
What is it?
Yeah, it's 20.
It's D5.
With 20 K.
D5 with potassium?
With 20
20.
KCl.
because most of our patients too, right, they have NG tubes.
Oh, you're.
I see.
Yeah, gastric losses, they're all, lose a lot of K.
Oh, okay. Here, we're gonna answer these last couple ones real quick.
There's still row. Row's
Oh,
done.
Ro. Sorry, Ro, your turn.
What did I just do?
Read it.
And then.
Wait,
Alvin?
what am I reading?
Guys, oh, no. We're gonna read the question and we just want you to answer. Okay.
Oh, okay,
Row,
all right.
your
Sounds good.
patient is pod number 1 with a large abdominal wall reconstruction secondary to a very large ventral hernia. She is now tachypnic with a respiratory rate in the 30s and shortness of breath. Why? What is your plan?
Oh. Why? What is my plan? Chest X-ray at first,
No.
so I can see
It's
it.
simple. If you didn't say it, you didn't do it. So what's the first thing you're gonna do? Yeah.
Assess the patient.
Thank you.
Good, you're gonna
Oh.
be like, that's like always, that's a thing.
Oh my god.
What do you do next? First, I'm gonna go see the patient, and then I'm gonna, like, always.
Do like a
Okay.
quick
Yeah,
exam. right?
exam. That's always an important thing. And vitals. I mean, this is kind of preparing you for orals too. Like you want to know, like what's the respiratory rate? All right, I'm going to put them on a pulse ox. So, like, their sats are 92%. I'm going to put them in supplemental oxygen, right?
Mhm.
But what are you thinking as you're starting to like just resuscitate and acutely treat this person of what might be the problem?
Large, what was it, large ventral hernia?
Yeah, read what
Very
the patient had.
painful.
Say that
Yeah.
again?
It
It's
was a
very painful, so are they on?
Pain.
It's very
painful.
painful.
Pain. That's a good one because sometimes with people, these massive abdominal wall hernias have what we call loss of domain, where their bowel has been out for so long, when you push it all back in, like they can't breathe. And so that can happen, but to me, that's kind of like a diagnosis of exclusion. So yeah, chest X-ray, all that, and they're at risk for what?
DVT, right?
Yeah, they're DVT, which
Its
means
respiratory rate is
PE.
high.
Yeah,
PE.
PE. The tachycardia is kind of what lets you know, like this guy might have a PE.
Shortness of breath.
Yeah. Okay, good. And if you think someone has a PE and you can't get them down to the scanner for like 5 hours,
I think it's
Treat it.
this one.
what are you doing?
Heparin.
Yeah, so you're gonna just treat. Anon just told us about a patient like that. They thought that he might have a PE. Okay,
I think they're still Alvin.
Alvin. Alvin, this one's for you.
Your patient is an 80-year-old and 2 days after like a colectomy with Hartman's for a perforated sigmoid cancer. He was quiet, alert, and conversive, but he is not very confused. It says he is not very confused and lethargic. Is that correct? But he is not very confused and lethargic.
I'm sorry.
He was quiet and alert and conversive, but he is not very confused.
Oh, but now he.
But now, okay, but now he is confused and lethargic, so he's fine, and then
Yeah.
he's confused and lethargic.
What do you?
What do you do, basically?
Yeah, what do you do? There's no question.
Just like, what do you do, I guess? Go see your patient. Yeah, I think this was
Yeah.
someone on there. Maybe he left or something. He might have left.
Why don't we do this?
We can just do it as a group.
So what was it? So what do you guys think?
He was.
It's altered mental status.
You
Yeah.
go see him.
I would
Go see him.
check his vitals for sure.
He's elderly.
Cultures,
Oh,
drug cultures.
Remember we talked about,
Elderly steps.
Oh, like expectation.
so delirium is something you might see a lot in your medical practice, but here that's a diagnosis of exclusion. When people have mental status changes in the surgical world, they're sick, there's something going on, you wanna make sure they're not like septic or whatever. So you're not, oh, he's sundowning, he's fine. You're figuring it out and making sure everything looks okay first. And then remember, we talked about elderly people, their reserve is different, so they may not get tachycardic. It's just vitals are just
Yeah.
don't hit like the norm for like bad stuff brewing.
Do you want to check his Foley? Like he probably has a catheter. in it.
Yeah,
You just
all those
see
things.
if there's any.
What does his belly feel like?
Yeah.
Is he new labs? Is he bleeding? Is he leaking?
Mhm.
Those two are the last ones. You guys give me guys.
Oh, God, oh my God.
Isn't that technically hypodelirium though? When they tend to become hypodelirious, because I remember there was a patient in IM that I had, and
That might be IM.
is that okay?
IM.
Whatever.
Yeah.
I'm sorry. I'm just. Forget I said it.
Wording.
All right, Whoa.
Oh, me first. Your senior and attending are in the OR with a perforated viscous. You are called with a patient whose heart rate suddenly jumped up to 140. He is post-op from a cholecystectomy and denies any pain, but feels chest pressure and short of breath. He looks scared. What would you do next? 140. Just post-op cholecystectomy. Chest pressure. Obviously go see him. I would want to see what his blood pressure is, if he's hypotensive. I would get an EKG on him. I don't know how, oh, he's seen, no, I don't know how old he is, but he's post-cholecystectomy.
Is he the kidney?
He's
at 140.
Maybe tropes too. Black tips for CP.
And I know when you order it, then you have to do the full workup. But like, do you do D-dimer always when you think it's
No,
PE or?
Never.
Okay.
Surgical patient, it's always gonna be.
Yeah, you
Okay.
can't, yeah, you
Okay.
can't trust it.
D-dimer is good at ruling out.
Yes, okay. But not
For
ruling it.
surgery, and they all have positive D-dimers.
Okay.
So good, you're captured most things, and these are like this is not like, you're calling and then you're going to see in consults, no, you're
It's all
like
at once.
taking care of this like now, okay? The reason I put that he looks scared. When people tell you they're scared or look worried or tell you they're going to die,
They do.
they do, every single time. So, and usually like with cardiac or like PE, there is that sense of doom, oftentimes like a big one.
Impending doom.
Maybe not like just a regular little tiny little PE, but like an impending doom. And so, you were concentrated on, like lots of us would be like, oh, what is this? Just had lap chole, it should be nothing. Or maybe, what is it? Oh, maybe there was an enterotomy. Yeah, but maybe it's medical, right? Or medical peri-op complication, which is more medical, like MI or PE. So, make sure to always keep those in mind. When I was a resident, I'll never forget this. I had a post-op CABG patient, and he was screaming. He's like, "Oh, I'm gonna die! I'm gonna die! I'm gonna die!" And I go in to see him. Like his chest tube output was fine, his vitals were fine, EKG was fine, chest X-ray. Like this was all like acute, but he kept saying, "Oh Lord, I'm gonna die! I'm gonna die!" And he did start getting a little diaphoretic, but everything was stone cold normal. You know what happened?
He died.
Do you have an MI?
I think he occluded probably one of his grafts or something.
Yeah.
Like it's just, And it was kind of frustrating because you're like, sometimes you get people and they're like kind of acting out. He was kept trying to get out of bed and he's like, I'm getting, I still can see his face and see the whole thing in my mind.
I think I'm gonna have to keep like, I just need 3 more days. I just need 3 more days. Day 3, dead. It's weird.
Yeah. My attending, he was our chairman. He told us about this 25-year-old woman who was getting a mitral valve repair when he was a medical student, actually. Or no, he was a resident because he was trying to consent her for surgery. And she's like, no, that's okay. I don't, just go ahead. I'll sign it. He's like, no, I really need to go over the risks and everything. She's like, no, I'm not going to make it off the table. He's like, what? It's just a mitral valve repair. She's like, no, I'm not going to survive. So I can sign it. I don't need to hear that. It was like, again, like straightforward, healthy-ish, just rheumatic, needs his valve, died. Yeah, so.
I don't think I would have operated on a patient who said that to me.
Who ever told me that, like, if somebody tells you they're gonna die, listen. So anyway, you'll get that sometime. So what's yours?
Okay, nurse call. She wants to confirm the order you put in for a 500 milliliter bolus of D5W for your post-op patient with the low urine output.
What do you think?
I guess let me make sure I did that.
These are your cells.
No.
The fluids are like this, so.
Yeah.
What's wrong with fluid?
It's the wrong fluids.
Does it sound like compatible with life and a good thing to bolus IV D5W? No. Extent, probably. That might be a huge problem.
Yeah.
You know what happens sometimes, like to all of us, like even that once you're attending, like somebody orders something or does something and you're just covering, and you get a call and God forbid you're in the middle of a bunch of stuff and you're like, yeah, you can go ahead and bolus it, no problem. Maybe you didn't really listen to like the D5W thing, or you're wondering, why is she calling me? Just bolus them. You gotta really just take the pause. You may be tired. You may trust who signed out to you. You may think it's no big deal or may not even understand it, but just like always kind of take that pause and make sure you're understanding what you're being asked, or take a quick peek at the chart, because you might be covering 40 patients during the night. Yeah. All right, thank you so much, Taryn. They were both amazing. I think they're gonna get a lot of questions right on their exams, and more importantly, when they're like roaming the halls, and I think that'll be because of you. Thanks.
Always here to help.
Thank you so much.
It's awesome.
Thank you, Dr. Aaron.
Yeah.
Thank you, Dr. Heron. Thank you, Taryn.
I think Jeremy's interested.
Oh, okay. So did he want to do it before while he's still?
Whatever, he just.
Oh, okay, so I'll just read it.
Yeah, he didn't know that it was like a youth thing. He just read that I was doing procedures. I would like love to help you with that. Yes.
So, because I was thinking the next one was going to be
Perfect.
Okay.
Taryn, I got a question.
Yeah.
So we're